some discussion. Uh-oh, I cannot advance. Let's see. There we go. All right. So first, I thought I would show just a snapshot of where I'm speaking to you from in the United States, from the city of Chicago, along the northeastern edge of the state of Illinois. And this is a snapshot of downtown with a very well-known sculpture called the Bean, although that's not its actual name. It is a beautiful city, but if anybody is interested in coming for RSNA or in the winter months, it can be extremely cold and windy, so be aware of that. I have no financial disclosures. Nobody pays me for anything other than my salary at the moment. So the outline for the next 40 minutes or so is pretty simple. I'm going to talk about Chiari 1's definitions, terms, controversies, some of the variations under the Chiari 1 umbrella, Chiari 2, some of the rarer Chiari nomenclature, and then very importantly, I think Chiari mimics and cases. And I would like to just recognize Hans Chiari here, who was an anatomic pathologist from Vienna, Austria, who worked in Prague and described these malformations initially from autopsy studies. So start with 1. What is a Chiari 1? So it's defined as an abnormality in which the cerebellar tonsils project a certain amount below the foramen magnum. So caudal projection of cerebellar tonsils inferior to the foramen magnum. If the tonsils are above the foramen magnum, assuming there's no other posterior fossa malformation, that's considered normal. If the tonsils are below the foramen magnum, that's ectopic by definition. But really, how low can you go before you're considered a Chiari 1? Well, pretty much everyone considers ectopia of more than 5 millimeters. So if you're 6 millimeters or more, to be a Chiari 1 and abnormal. That does not mean it's symptomatic. It may or may not be symptomatic. If the tonsils extend less than 3 millimeters below the foramen magnum, they're still technically ectopic by definition, but that's typically not considered to be clinically significant, with a few caveats that I'll talk about shortly. That range of benign tonsillar ectopia has been extended up to about 5 millimeters in the mid-childhood range. And I do want to mention that these measurements are really derived from pretty old historic data. And I want to show some of that initial data. So this is an older study from 1986 by Berkovich Sr. and colleagues. And it was one of the original sentinel imaging descriptions of this abnormality. And what they looked at was the tonsillar position for normal patients that had no symptoms and Chiari 1 patients that had Chiari 1 symptomatology. And I'll just do a little sidebar here about what Chiari 1 symptoms can be. Headache, neck pain, often exacerbated with coughing, straining, or positional differences, vomiting, imbalance, nystagmus, respiratory difficulties, weakness, tingling, scoliosis. So really a variety of clinical symptoms, none of which are entirely specific, and some of which, like headaches, are very, very common, although I do think the headaches exacerbated with coughing and straining is somewhat more indicative. So what Berkovich and colleagues looked at was the mean tonsillar position for normal versus Chiari 1 is clearly very different, right? 1 millimeter above to 13 millimeters below. But if you look at the range, there is some overlap. So normal 8 millimeters above to 5 below, Chiari 1's 3 millimeters below to almost 3 centimeters below. So we do have some ambiguity in this 3 to 5 millimeter range. Also, this initial literature is often the case, isn't really derived from a very large number of patients, right? The symptomatic patients were only 25 in number. So this is a quote from a subsequent retrospective analysis about 15 years later. So now we're up to 2001, which I think summarizes a lot of the studies done in that time period and eloquently illustrates the difficulties with the strict measurement definition of this disorder. And they concluded, looking at this meta-analysis, that radiologically significant tonsillar ectopia may be completely asymptomatic, and also that there are patients in whom the tonsillar herniation extends less than 5 millimeters, but who really are demonstrating either Chiari 1 symptoms or have an associated syrinx. So there are some other confounders to the strict measurement definition as well, and that's that it's not always that easy to measure. If we think about CT, and a lot of kids will come through the ED and get a CT for headaches, we want to look at this area. Can be difficult due to angulation, although I think reformats are so much more common now on standard head CTs that that's less of a problem. But beam hardening artifact through the foramen magnum absolutely is, and that's not going to go away with reformations, right? On MR, it can also be problematic. Where are the bony margins of the Bayesian and opistheon? And we don't really see the bony cortex very well on most MR sequences. If you have a T2 sequence, some of the flow artifact can kind of obscure the tonsils, make it difficult to measure. What about head position? If you're an extreme flexion or extension, that's absolutely going to change how much the tonsils are extending. And what if the tonsils are asymmetric? If one's just a little bit droopy and the other one's not, what do you do about that? So the most accepted way of measuring for Chiari-1 is really derived from some of that earlier studies by Barkovich and colleagues. And it's typically drawing a line along the lower margin of the foramen magnum here, find signal intensity on T1 imaging. So draw a line on T1 imaging from the low T2 signal there to the low T2 signal here. And then to drop a line perpendicular down to the lower of the two tonsils. So there have been plenty of subsequent investigations proposing other ways to measure, often in the coronal plane, and some have said that this is more accurate and that sagittal imaging either overestimates or underestimates the exact tonsillar position. But I think honestly, most of the data we have does come from sagittal imaging, and a sagittal T1 is standard in most MR protocols. So this is really what most radiologists are going to use. Another issue with measurement criteria is that it has been reported that some patients have Chiari symptoms and physiology without significant ectopia. And this has occasionally been termed a Chiari zero malformation in the literature. And this really comes from an older study that was relatively small study where patients with either Chiari-1 symptomatology and headaches or syrinx underwent surgery to relieve the compression and had clinical improvement or resolution or improvement of the syrinx. So this was a retrospective analysis on a very small series. It's not a widely accepted term. I don't like it. I would never use it. I don't think you should use it, but I do think it brings up an important point that measurement alone is a poor descriptor of the significance of this entity. So if measurement of the ectopia is basically what defines a Chiari-1, but I'm saying, and I'm backed by the literature, that it doesn't correlate very well with clinical significance, what else do we look at? And there are a number of things. Look at the morphology of the tonsils. Are they tapered and peg-shaped? That's more associated with clinical significance than if they're nice and happy and rounded in contour. Look at the crowding of the posterior fossa. Is the cisterna magna compressed? Is the cervical medullary junction distorted? Is there effacement of the surrounding CSF? All very important findings that tend to indicate a more significant, clinically significant abnormality. Look for associated syrinx. So we know that syrinx is associated with Chiari-1, probably about 10 to 20% overall, but much more common in symptomatic patients. So if you have a syrinx, much more likely to be a symptomatic issue. Typically, when we see a syrinx in Chiari-1, it's either cervical or cervicothoracic, although isolated thoracic syrinxes do occur. Probably somewhere between 6 to 8% of patients that have a syrinx will be isolated to the thoracic spine. So if you're doing an initial imaging investigation for these patients, I do think it's worthwhile to do the whole cord and not just the cervical spine for the first time. You also want to look at the skull base, attention particularly to the clivus and the odontoid, because abnormalities here can affect how symptomatic things are. And I'll talk about this in just a minute when we discuss more complex Chiaris or Chiari 1.5s. And then what about CSF flows? So if the symptoms are assumed to be due to CSF obstruction, and these other features are really indirect signs of that obstruction, why not just directly look at CSF pulsation? And we can certainly do this. We can do a functional assessment of CSF flow. There are a bunch of techniques out there. I think the most common is phase contrast cine imaging with velocity encoding, but there are different techniques. And they're all a little bit challenging to perform in this area because it's common to have aliasing, vertebrobasilar pulsation from vascular artifact. where exactly, if you're doing quantification, do you measure? What should the head position be in? And at the moment, for quantitative analysis, there's not really good, reliable, established pediatric criteria. Even in adults, for which there's generally more data, there doesn't seem to be a really good quantitative distinguisher between who's going to be symptomatic and who's not going to be symptomatic. This is just a little blurb from an older AJNR article, kind of talking about flow jets, bidirectional flow, and peak velocities. And they did find some difference between patients who were symptomatic and not symptomatic with tonsillar ectopia, but not really statistically significant. And this is an excerpt from a subsequent meta-analysis in 2015, looking at a bunch of different papers, and also, I think, reflecting that inconsistent performance of quantitative analysis to predict symptom relief from Chiari 1. So they did see differences, but applying them to who's going to respond to surgery or not was problematic. I do think qualitative analysis can be helpful to look for reduced flow around the foramen magnum. It is rare to have a symptomatic Chiari 1 if there is very good flow, ventral and dorsal, to the foramen magnum. There are varying opinions about how much this adds value over anatomic imaging, but many centers do it and do find it helpful. At our primary hospital, we do this very rarely, but one of our offsites that we read from a community hospital does it quite a bit. And I think the more you do it and you gain experience and optimize the technique, probably the more helpful it becomes. Uh, Also, if anybody's interested in technical details, this is a more recent review from 2023 from the Journal of Magnetic Resonance Imaging that really nicely summarizes a lot of the different CSF flow techniques. Another feature of Chiari 1 to keep in mind is that it changes over time. There's a relative growth of the cerebellum and calvarium that results in reports of both spontaneous resolution and development of Chiari 1 during childhood. So here is an example. We have a 6-year-old, tonsillar ectopia, fairly significant tapering, some crowding at the foramen magnum. Follow him up 10 years later, and yeah, the tonsils still are a little ectopic. They look maybe a little bit tapered, but there's really no crowding. There's much less compression here at the foramen magnum. And conversely, here's a patient who's a year and a half, tonsils above the foramen magnum, nicely rounded. Follow him up a few years later, and maybe this isn't quite 6 millimeters, hard to tell, but the tonsils are definitely below the foramen magnum, and it now looks a little bit crowded. And in practice, we absolutely do see this change over the childhood period. This is another example, 4 months above the foramen magnum, 3 years extending below the foramen magnum, probably more than 6 millimeters, looks a little bit crowded. And this to the right here is actually a recent example from last month that I came across. That's one of the more dramatic changes. So at 4 years, a significant Chiari with tonsillar ectopia, tapering, distortion, crowding, effacement of the CSF. A few years later, much improved, and by 9.5 years, looks pretty much normal. So this has led to a movement to kind of rename these not as Chiari 1 malformations, but as Chiari 1 deformities, because malformation really connotes a congenital structural defect typically present at birth. And we know that that's not necessarily true in this case. In terms of reporting, this is my personal approach. I take just mine. I think that for me, the concept that these abnormalities are not static in childhood is important. I don't like the term deformity because it has a bit of a negative association in vernacular English, and our patients do get copies of their reports. So I just sidestep all the semantics and I just call them all Chiari 1s. No deformity, anomaly, malformation, or whatever. I could not be bothered with that level of detail. So I just call them Chiari 1s. If the tonsils are 6 millimeters or more, I will call that in the impression as consistent with Chiari 1 and mention specifically if there is crowding present or not. If it's in that 3 to 5-ish range, I will call that mild cerebellar tonsillar ectopia, and I will mention if there's crowding or not. If there isn't crowding, sometimes I'll put of uncertain significance, particularly if the indication for the exam is not one that is of Chiari symptoms. I really think in that range, you got to kind of punt it back to the clinician to see if they think what's going on could be related to a Chiari. If it's less than 3 millimeters, I will typically say the tonsils extend slightly below the foramen magnum. If there's no crowding, I will often just say of doubtful significance and leave it in the body of the report. I think if we make a big deal about this, we are actually basically making kids get a lot of follow-up imaging that maybe they don't need. Let's talk a little bit about treatment. So, other than just waiting for for a child to kind of grow out of it if they're not very symptomatic, the primary treatment for Chiari 1 is suboccipital decompression. So, what the surgeons will do is a suboccipital cranioplasty, where they take off the posterior aspect of the foramen magnum here, the bony foramen magnum. Typically, we'll do a dorsal C1 laminectomy as well. Then we have a couple of options for the surgeon. They may do a duroplasty or scoring to increase some of the space back here. And once the dura is transgressed, if there are any adhesions there, they can lyse those, or even resect or coagulate the ectopic tonsillar tissue, which isn't really eloquent. So this is a postoperative patient who had a Chiari 1 and a significant syrinx. And here you can see that they've taken off the back of the foramen magnum, done a dorsal C1 laminectomy, a duroplasty with improved fluid around the neoforamen magnum, and significant improvement in the syrinx. So overall, there are slightly better outcomes with duroplasty, but it does lead to the possibility of developing a pseudomeningocele from CSF leak. So in this patient, we can see the dark line of the duroplasty here, and then this is CSF and the suboccipital soft tissues. So this is a potential complication. Usually these resolve on their own, although occasionally they do have to go in and repair if there's a real defect in the duroplasty to get this to the resolve. And these are just some gross pictures of that process with a nice picture of the duroplasty graph. So the patient's head is down and we're looking at the back of the cerebellum. This is from one of our excellent neurosurgeons here at Lori, Art DePatri. And the majority of patients, suboccipital decompression will stabilize or typically improve symptoms after surgery. And most patients really only require a posterior fossa decompression plus or minus duroplasty. There is a subset of patients that maybe don't respond quite as well to that surgery. And those are what's termed Chiari 1.5 or complex Chiaris. I think Chiari 1.5 is the preferred term, but I do see both in the literature. And this really was described in the neurosurgery literature about 20, 25 years ago, and then took about a decade to kind of percolate into the radiology literature. So what is this? In addition to tonsillar descent, there's typically some caudal descent of the brainstem, and most characteristically, there are skull base abnormalities. So hypoplasia or platybasia, you get a small hypoplastic clivus that is horizontally oriented, as we can see here. Often the odontoid is retroflexed, and then because of those changes, there may be a basilar invagination component of this. Some of the definitions of Chiari 1.5 include the clival canal angle. So you draw a line along the posterior aspect of the clivus and then the posterior aspect of the odontoid. And this part ventrally is the angle you want to measure. Normally that's an obtuse angle about 150 to 180 degrees. As it becomes more narrowed, you get more compression ventrally. So they say about less than 140, 143 degrees correlates with a Chiari 1.5. The other measurement that people will use is the PB to C2 line. So you drop a line from the tip of the clivus to the posterior aspect of the C2 body, and then perpendicular how far back the odontoid tip is. So it's basically a quantification of the degree of retroflexion. And if that is more than 9 millimeters, that's typically associated with a Chiari 1.5. So why is this important? Well, these patients are by most accounts more likely to, one, have a syrinx, and two, to be symptomatic. It's probably because they have that ventral compression component in addition to from tonsils. So there's also data that these patients may respond less favorably to the traditional posterior fossa decompression, presumably due to persistence of that anterior crowding component. Many of them may require a second surgery, and there has been some reports of people suggesting that at the time of suboccipital decompression that they're also undergo an occipital cervical fusion, because if you just take off the posterior aspect of the elements here, sometimes it destabilizes things ventrally. So this is a patient that has suboccipital decompression. I think that's probably the bony margin back here. They did not do a C1 laminectomy at that time, which is a little unusual, but still. If we look a couple years later, what's happened is the school-based changes have actually exacerbated, and now there's greater crowding and development of a syrinx. Now, at our institution, we do not do anything different surgically. We will still do the suboccipital decompression, but we do follow those patients more closely. And the counseling for the patient and their family is a little bit more guarded in terms of potential outcomes and the possibility for needing another surgery. All right. Let's move on to number two, Chiari 2. So this we can comfortably call a malformation. In the past, these have also been referred to as Arnold-Chiari malformations after this gentleman, Julius Arnold, who was a German pathologist in the late 1800s. However, there has been some confusion about which types of Chiaris were actually described and what constitutes an Arnold Chiari. So in general, this is considered an antiquated term and is rarely used because of potential ambiguity. So we're good for the malformation portion, but with all respect to Dr. Arnold, I would not use that term. We'll just call it a Chiari 2 malformation. So what is this? This is a more complex posterior fossa malformation characterized by herniation of cerebellar tissues through the foramen magnum, as well as brainstem through the foramen magnum, often with a cervical medullary kink, as we can see here. The posterior fossa is typically small with inferior positioning of the torcular confluence. The fourth ventricle is typically elongated and compressed. There may be tectal beaking, actually not on this image, but the posterior aspect of the midbrain sometimes has a peaked contour. There may be an enlarged massa intermedia. You can have fenestration of the falx, so interdigitation of the parasagittal gyri. The tentorium is often also dysplastic, leading to a towering cerebellum type appearance. And hydrocephalus is pretty common. You can see a tip of a shunt here. The other thing that these patients have is nearly 100% will have an associated myelomeningocele. In fact, it's probably the myelomeningocele that is the primary structural abnormality that then leads to these other changes. So a myelomeningocele is a failure of dorsal fusion during embryogenesis, and the neural placode and subarachnoid fluid extend through a dysraphic defect. And this is actually a post-repair, so there is some soft tissue over here, but pre-repair, it will only be covered by the dural sac, so it's an open neural tube defect. Here's another example just to show some of those additional Chiari 2 findings. So posterior fossa small, inferior torcular herniation of cerebellar tissues and cervical medullary junction, crowding at a dysplastic appearing foramen magnum, and that towering cerebellum appearance. The herniated cerebellar tissue in Chiari 2s is typically dysplastic, and it can have cystic degenerative changes and degenerate quite a bit. This is an example of a rather significant Chiari 2, right? Really small posterior fossa, extensive herniation of brainstem and cerebellar tissues. And there are some cystic changes in that ectopic tonsillar tissue. Here's another look at a different patient of some cystic changes, a nice macroscopic view for comparison. And in this instance, maybe some cystic changes, and there's been so much degeneration that it's really difficult to visualize any ectopic cerebellar tissue here. Another thing to keep in mind is that if these patients get contrast, and you don't need contrast to evaluate for a Chiari 2, but obviously they can have other things going on. And if you give contrast, sometimes there's some unusual enhancement related to either distorted choroid plexus in the fourth ventricle, or sometimes even venous congestion from crowding at the foramen magnum. So I have seen these sometimes misinterpreted as a JPA or a tumor with some cystic changes and enhancement. How about this child? Does this have a Chiari 2? Well, posterior fossa is pretty small. Some caudal extension of cerebellar tissue here, but fourth ventricle doesn't really look elongated, no tectal beaking. So the Chiari 2 changes can be actually pretty subtle. If you're going through your case stack and you're not sure if something's a Chiari 2 or not, and they're followed at your hospital, the easiest thing to do is to look in the chart and see if they have had a repaired myelomeningocele. But the appearance of Chiari 2 is actually changing and evolving as treatment has advanced. And that brings us to the major advancement in chiari-2s, which has really revolutionized how we think about this disorder in the past decade, and that's prenatal repair. So about 15 years ago, 2011 here, there was a large randomized prospective trial looking at fetal repair of myelomeningocele, so-called the MOMS trial, started in Philadelphia, so Management of Myelomeningocele Trial. And they really found significant improvement in outcomes with prenatal repair, including reduced need for shunting, improvement in neurologic capabilities, improved ambulation, and I think most interesting from a radiologic perspective, reversal of that characteristic hindbrain herniation that we are used to thinking about in Chiari-2s. So this is the actual New England Journal of Medicine article. And although the outcomes are undeniably better, there is obviously some risk to both the mother and the fetus. So this requires an experienced fetal neurosurgeon, and that's typically only available in select specialized centers. So because of lack of access and resources, as well as some moms not being really good surgical candidates, I think we're going to continue to see a mix of pre and postnatal repair appearances for this disorder. So I'll take a brief minute just to describe the fetal assessment of Chiari-2. What are we looking at when we try to evaluate these patients? Well, a big one is to distinguish it from other entities, particularly closed neural tube defects, of which the major distractor is myelocystoceles. So, myelocystocele is dilatation, often cystic dilatation of the central spinal canal, herniates through a posterior dysraphic defect. It looks very similar, but it is skin covered, so it is a closed neural tube defect. We also want to look for other CNS anomalies. We know that Chiari-2s are associated with other structural abnormalities and dysplasias. Often, if we are doing an MR, we're doing it, at least in the US, at the 20 to 23-week gestational period. So it's a little limited looking for other abnormalities, but definitely important thing to look for. We want to know what the level of the myelomeningocele is. If it is above T4 or below S1, there's not really as much of a role for prenatal repair. I have seen our surgeons have a little bit leeway on the caudal aspect of that, but they certainly will not go higher. We want to know what the degree of hydrocephalus is and how much herniation in the posterior fossa. And here's a example of a Chiari-2 fetal MR where there's herniation of cerebellar tissue, brainstem, complete effacement of the surrounding CSF. There is some hydrocephalus, and there is a low-lying cord. I don't know what level we're at here, but we're definitely in the sacrum. There's dysraphism with splaying of the pedicles here. And here we don't really see a dural sac, so either it's so thin and our technique wasn't great, or it's more of like a schisis and it's open to the CSF. There is a grading of the posterior fossa changes on fetal MR. So grade 1 is typically almost normal. Maybe the tentorium is a little bit downward sloping, but there's no significant ectopia, compression of the fourth ventricle, or cisterna magna. So here in a twin pregnancy, this is the lumbosacral myelomeningocele on this twin. And the posterior fossa, I'm a little bit off midline here, so you can't see the fourth ventricle, but otherwise looks pretty normal. Would be hard to tell that something is amiss there. Grade 2, there's tonsillar, or rather cerebellar ectopia, effaced fourth, but the cisterna magna is patent. And then grade 3 is really everything compressed ectopia with no identifiable cisterna magna effaced fourth ventricle. So I talked about myelocystoceles briefly earlier. I think this is one of the major distractors when we're looking at fetal imaging. And this is a closed neural tube defect. The difference by imaging is that, again, it's thick, it's covered by skin, not just dura. So the lining should be thicker and more easily identifiable. I do think that this is actually easier to see by ultrasound, actually. Other things that you can look for are hindbrain herniation, which typically we do not see with myelocystoceles, although one, there have been some reports of that happening, and two, as we saw with the grade 1 Chiari changes, some of the true Chiari-2s don't have a whole lot of hindbrain herniation early in pregnancy. If they have an amniocentesis, the myelocystoceles will not have elevated amniotic AFP. And the big reason for distinguishing them really is that as a closed neural tube defect, they are not a fetal surgical candidate, whereas myelomeningocele are. So this is an appearance of a Chiari-2 fetus 22 weeks pre-op. and this is post-op fetal repair. And I think it's a nice example of how much the herniation of the hindbrain has reversed, and even the enlargement of the ventricles has significantly decreased. On the pre-surgical, we also see some flattening of the frontal bones, the kind of lemon head configuration that we're used to seeing on ultrasound, and that has resolved quite a bit. So another way fetal surgery is actually changing the imaging appearance has to do with epidermoid inclusion cysts. So epidermoid cysts have always been a known potential complication of repair, likely from some trapped skin cells during that repair, and then you end up with the progressive desquamation that creates these dermoid or epidermoid cysts, typically T2 hyperintense, almost fluid in appearance, but will diffusion restrict. And with fetal repair, we are seeing them more commonly, although there's some debate about that, and definitely seeing them earlier. I used to not see these until a kid was like 5, 6 years or older, and now sometimes we'll see them at a year or 2 years. I just want to touch very briefly on some of the few chiaris beyond 1 and 2 that have been reported. These aren't widely used terms. I think there is some question regarding the actual definitions, but I do see them from time to time. So chiari 3s are reported to be posterior defects with herniation of cerebellar and sometimes occipital tissue. So it's basically a cervical occipital cephalocele. Chiari 4s or Chiari 2s, but the cerebellar tissue is markedly hypoplastic and the brainstem is hypoplastic. So here, this would be a Chiari 4 where we can see a little bit of ectopic tissue in the upper cervical spinal canal, but really the cerebellum is markedly diminutive and the brainstem is very slender. Chiari 5s have been described occasionally as herniation of the occipital lobes through the foramen magnum. I will occasionally see these terms mentioned, but I think because of ambiguity of the definitions as well as their rarity, I generally prefer a descriptive approach rather than a named label because it can be kind of confusing. One very important thing to keep in mind when considering chiaris is the essential importance of distinguishing a developmental chiari from an acquired chiari. So one of the situations where we will encounter an acquired chiari is with intracranial hypotension. So if we look at this child to the right here, we absolutely have cerebellar tonsillar ectopia and crowding, but there's more than going on than just ectopia. There's sagging of the entire posterior fossa, right? The cisterns are effaced, the brainstem looks a little bit flattened. If you give contrast for patients with hypotension, dural pachymeningeal smooth enhancement and thickening are very common. You can also see subdural effusions. Venous congestion is common. Here we can see some prominence of the venous sinus of the torcula. The suprasellar cistern is typically small with inferior displacement of the hypothalamus and chiasm. So what about this patient? Did this patient have a Chiari 1? Well, this is actually imaging from an outside institution that was transferred to Lurie Children's. And the report was a normal MR of the brain with the exception of a Chiari 1. And the tonsils are definitely ectopic here, but it also looks like there's some greater, more extensive crowding of the posterior fossa with a real small fourth ventricle, kind of narrowing of all of the cisterns. Even supratentorially, we don't see the sulci very well. Maybe the cortex looks a little bit T2 hyperintense, but I think the most significant finding is the child had had a CT at that hospital on admission several days before, and there's no crowding at the foramen magnum. Now we know the Chiari 1s change over time, but that's over years, not weeks, not days. So this really isn't going to be a developmental Chiari 1. If we look more closely on diffusion imaging, and this can be difficult to pick up sometimes because it's diffuse and symmetric, but there is restricted diffusion throughout the bilateral hemispheres with sparing of the cerebellum. And if we look at a follow-up CT, we can see that there's been extensive entry to the supratentorial parenchyma. So this is an acquired Chiari because of descending tonsillar herniation secondary to increased intracranial pressure. So do remember that we encounter herniation, acquired herniation from increased intracranial pressure and hypotension as well. Excuse me. How about this patient? So these are two single shot T2 images. Sorry, I can't get the H to go away on these images, but this is from a rapid non-sedated exam, which we are doing more often. I think other centers are too, to look for ventricles and other things to allow us to do an MR exam without having to sedate young kids that couldn't otherwise make it through other types of rapid sequences. So here in this study, we thought maybe there was some cerebellar tonsil atopia and crowding here. We caught it at the time of the exam. Often we'll be called to check these studies, and added on a rapid T1. And you can see that the tonsils are really terminating much above the foramen magnum. So I actually think this is the margin of the tonsil. And all of this is CSF flow. But I do think it's worth noting, as we're doing more of these rapid studies with T2 sequences, especially the single shot T2s, but really any T2, you can get some pulsation artifact from the CSF that makes it difficult to see where the tonsils actually are. How about this patient? This was another patient who was called a chiari 1. The tonsils aren't really ectopic. There certainly is crowding at the foramen magnum, but not all crowding at the foramen magnum is due to a chiari. And in this instance, we also have what looks like an irregular contour of the dens. There's a little bit too much T2 hypointensity posteriorly, maybe some ligamentous thickening. The dorsal C1 arch is hypoplastic, and maybe there's a little bit of dysplasia of the vertebral bodies. If we look further into the child's chart, there's more characteristic anterior-inferior beaking of the thoracolumbar vertebral bodies, and he also has dysplastic appearance of the metacarpals and phalanges with a characteristic kind of bullet-shaped contour. And this was a mucopolysaccharidosis. So not everything that's crowding at the foramen magnum is a chiari. Do look for those other osseous abnormalities. How about this patient? So definitely too much soft tissue at the foramen magnum. Could that be ectopic tonsillar tissue, something else? Maybe if we look a little bit more cephalad, there's also an unusual contour of the posterior aspect of the foramen magnum. A little bit of high density here, maybe calcification. And if we look on MR, there's a enhancing fourth ventricular mass here. This turned out to be an ependymoma. So I think what we're seeing here is probably a combination of tumor and some acquired tonsillar herniation from mass effect. The ependymomas in particular, if they don't have cysts or calcification, can be a little bit difficult on CT because they're normally near isodense to parenchyma. All right, so some key points for chiaris. For chiari 1, 6 millimeters or more is the most accepted measurement for chiaris. Look also for crowding, tonsillar contour, loss of surrounding CSF that really do implicate more of a symptomatic issue, more than just the measurement alone. Remember that not all chiari 1s are the same. You can have ones with these skull-based changes in a more complex configuration that are likely to be more symptomatic. Consider imaging both the cervical and thoracic spine to look for a syrinx. And CSF flow studies have variable utility, a little disappointing on the quantitative side, but qualitatively, I do think have a role. For chiari 2s, these are more complex malformations, often associated with hydrocephalus. Almost 100% of them will have myelomeningocele, and there is a changing appearance in the era of fetal surgery. Do remember that there are mimics of chiari abnormalities. You can get acquired chiaris from herniation or hypotension, from tumors. Also, you can be misled by CSF flow artifact and other skull base or osseous abnormalities. And I think I had some references through the talk. These are a couple of nice review articles for anybody interested in further reading. And this is my institutional email and a picture of the shores of Chicago. All right, I think that was actually a little bit shorter. Get nervous and I speak a little bit more quickly, but I am happy to take any questions.
Thank you so much, Maura. That was an incredible talk and some awesome cases that you've shown us. I'm going to start off the questions with one of my own. Actually, I have two questions. In chiari 1 malformations, is there a certain criteria as to when to operate, like unless the child is symptomatic or something, is there some objective criteria, or does it differ from surgeon to surgeon? And if we don't, or if we choose to not operate, what is the recommended follow-up imaging time, sort of timeline that you're looking at? Like, do you suggest a certain amount of time for follow-up, or is it a decision taken by the surgeon or the parents or something like that?
Yeah, so there is, I think, variability from surgeon to surgeon, and I think there's a huge clinical component there. I have seen some that actually look kind of impressive on imaging, and they will continue to follow them. Sometimes, and I don't know if this is the same in India, but in the U.S., the parents have a lot of input too, and some parents just don't want to do surgery, or they really do want to do surgery. So I think there's a patient preference component to that as well. If there is a syrinx, they are much more likely to operate because even if that child doesn't have symptoms associated with the syrinx, you kind of want to get to it before they develop those symptoms of, arm weakness and such, because they may not always be reversible. So I would say syrinx is not absolute, nothing's absolute, but is a very strong indicator that they are going to undergo surgery. Otherwise, a lot of it is clinical. Do they think that, many of these kids are getting imaged for headaches? Do they think that the headaches really are more of a chiari 1 symptomatology? And then for the ones that they choose to follow, because we have a pretty close relationship with our neurosurgeons, I usually do not put that in the report, like follow-up suggested, whatever time period, because I don't want to tie their hands if they have a different appearance. If I'm asked by some of our community physicians and such, I will typically say 1 year, as long as they're not having any change in their clinical symptoms or whatever had led them to have um, the uh, the study in the first place. And honestly, if they're very young kids, sometimes we will do some of these fast T2-based MR ventricle studies just to follow it if they don't want to sedate the patient. And once you know where the tonsils are from a standard MR, I do think it's easier to figure out what's going on one of those rapid T2s. So that's what we do. It's if there's a syrinx, much more likely to operate. Otherwise, largely based on the clinical picture and surgeon preference, as well as some family input. And if they ask me when they should re-image them, I will usually say 1 year, provided there's no interval clinical change. And if they're very young, I am actually okay with doing one of these rapid studies and not having to sedate or anything.
Thank you. So I'm going to go on to the questions by the attendees. The first question is from an anonymous attendee. The question is, do you personally have any experience or information of about doing vertical MR versus supine MR in chiari 1, and whether these positional changes contribute to our understanding of this condition, especially in borderline cases?
Yeah, so position is a big black box of question. And in terms of supine versus upright or sitting, we have not done that. I think that might be technically a little bit challenging to do, but we have difference in head positions all the time, either because of how the child is lying or if they are intubated for a study, anesthesia is the one that's basically positioning them. We have occasionally done studies with patients' inflection and extension purposely to kind of see if it changes the crowding, especially if we're trying to do a CSF flow study. I think we don't do enough of those to get a good sense of how valuable that is. If you only do a study once in a while when it's a questionable case, it's maybe not as useful. But I would say that head position and, to extrapolate from that, supine versus upright is absolutely going to be a consideration. And it may be at the root of part of the reason why measuring these or doing CSF flow studies is so sort of underwhelmingly helpful in terms of predicting who's going to be, who's going to respond to surgery or not. There have been some studies specifically about CSF flow with people doing coughing or different types of breathing, and it absolutely changes it. How we can incorporate that into our daily practice, I don't know. It's a difficulty. And even when we're measuring them, the same child in a short period of time, especially if they're being imaged for something else and they just have tonsillar atopic. So you'll see 1 week 'cause they have ADEM or something like that. And their head position, it really does change how it looks. So I think that's a great question. And I think it's probably a big area of uncertainty and maybe, as I said, at the root of some of the difficulty in using measurement or quantitative criteria to kind of suggest who might be symptomatic and who might not be.
The next question, I think you've already answered about the role of CSF flow study in chiari 1 and 1.5. Do you want me to move on, or I think
Yeah, I would just say again that the quantitative data on that, if you're you're trying to use it the way you might use flow through the aqueduct for NPH or something, that's been a little disappointing. But qualitatively, yes, I do think it is helpful. And again, the techniques are a little difficult. So like anything else, the more you use it, the more you become comfortable and good at it, and the more helpful it can become. And I do think it is rare to have a symptomatic chiari, rare but not impossible, when there's really good flow visually through that. I personally, we do use it, our techniques, because we don't use it as much as we should. So it depends what tech is on, what the venk was. We kind of screw up a fair number of them. I do like actually really high resolution imaging. I think it gives me a good sense about what the patency of the CSF around there. So sometimes if I have a question, I might add on a steady state sequence like a KISS on Siemens or a Fiesta on GE. I think that gives me about as much information, but that may partly reflect the fact that we don't use it as much here as other places do.
got it. Can you help us differentiate between chiari 4 versus Dandy Walker malformation?
Yes, so Chiari 4 with the actually, should I go back and do a picture of that? Chiari 4 with the very hypoplastic cerebellum and thin brainstem. In fact, let me see if I can just go back to that picture so I can kind of show you. Okay, I guess yeah, here we go. Whoops. Here we go. So in a Chiari 4, it looks like, yes, it looks like there's cystic stuff here, but the posterior fossa is still going to be overall small, and the torcula is still going to be overall inferiorly displaced, whereas a true Dandy Walker malformation, the posterior fossa is going to be enlarged, and typically the torcula is elevated over the lambdoid suture, if you can kind of see that area. So large posterior fossa for Dandy Walker, small still for a Chiari 4. Also, there are, as you know, a lot of other abnormalities along the Dandy Walker spectrum or continuum. So that in itself could be a whole, hour lecture and discussion of those entities. But typically, they won't have any sort of caudal descent of cerebellar tissue the way we can see here. So I think that's a useful feature.
Got it. What is the cause for the sittings in chiari?
So the actual pathophysiology is a little bit unclear, but it is probably due to obstruction of CSF flow at the foramen magnum, as well as compression of the obex, which then leads to dilatation of the central spinal canal.
Okay. The next question is acquired chiari similar to intracranial hypotension or hyper?
You can see it with both. So with hypotension, you get sagging of the posterior fossa, and with hypertension, you get increased pressure that pushes the tonsils down. So you can see it with either hypo or hypertension. Now, with the idiopathic pseudotumors, that type, so the hypertension effectively or increased intracranial pressure that I showed there was from a diffuse anoxic event. But if you have hypertension in the terms of like pseudotumor cerebri, I have seen it, but very rarely. Usually I will see other signs before that, particularly papilledema, or sometimes, like an empty cella from Mass Effect, that kind of stuff. So you can see it in both hyper and hypo.
Got it. The next question is, can a syrinx occur without chiari 1?
Yes. Does it occur because of a Chiari 1? There's no obstruction there, and that's the reason the syrinx. Possibly. I think there were a couple of times was, can you have a syrinx without a Chiari? And the
Correct.
answer is absolutely you can. I think in some instances it's because there are septations, so there is actually obstruction at the CBJ that we don't pick up on standard imaging, but there are plenty of other causes. The most common one that we will encounter is from tethered cord. So syrinx is a sign of tethered cord syndrome. The pathophysiology and mechanism of that is far less well understood, but the association is clear. And then we can see it if you have a tumor occasionally, although typically you can see the tumor at the time that it's causing a syrinx. And there are a number of kids that have what gets billed as an idiopathic syrinx, where we never really find out why it's there.
Got it. Um, so, okay, just give me a second. Sorry. How do we label tonsillar ectopia in elderly patients who have non-specific complaints? Can we still call it a chiari?
So I am extremely fortunate to not have to read any elderly patients. I'm 100% pediatric neuroradiology, so I'm going to say I do not know on that one, and I'm very blessed in my job to not have to worry about that.
Same here. Got it. Okay. So what is the absolute indication of fetal surgery in the light of changing scenario for chiari that is seen even after birth?
You mean postnatal repair? Is that what
I,
they're
I
asking? Yeah.
I think so. I'm a little unclear, to be honest.
Yeah, so the indications, there are a number of criteria for the mom for fetal surgery where they won't be eligible for fetal surgery. One of the big ones, and I can't remember what the cutoff is, but is BMI. So patients that are very obese, they can't really do that. Otherwise, I think the major limiting factor to fetal surgery, in addition to the things that I mentioned, like the level of the meningocele and such, is really access. And also hopefully that they have identified this prenatally. Sometimes if somebody's not getting prenatal care, and that certainly happens again, access is an issue. And in the US, expense for medical care is really spiraling out of control. So there are a lot of people that are not getting follow-up because they can't afford it. So we do see postnatal repair all the time, because there aren't enough fetal surgeons to do all of this. It's expensive, that sort of thing. So I think we're still going to see a mix of what it looks like fetal repair and postnatal repair. And even if everybody could have access to fetal repair someday, if we're able to achieve that, there are some features of the mom and the meningocele that may not be amenable to prenatal repair.
Got it. What MRI changes would constitute a successful Chiari-1 surgery? Thank you.
So what I will usually talk about when I'm reading those postoperative, one, if they have a syrinx and the syrinx gets better, that's successful, and that's a pretty easy thing to see by imaging and to quantify. Then the other part is to look at the residual crowding. So after surgery, I'll call it a neo foramen magnum because it's a new foramen magnum. And I want to look to see if there is preserved CSF surrounding that site. And also the tonsillar contours, although sometimes that's a little bit misleading because, as I said, one of the things they will do occasionally is coagulate and resect that tonsillar tissue, so it makes it look more rounded. But primarily, any change in the syrinx and improvement in compression of the fluid around the foramen magnum.
Got it. I think that's all from the attendees. I do have one more question, if you
Yeah.
don't mind, the last one. Do you often see asymmetricity in the degree of tonsillar ectopia, like when it is not pointed, the cerebellar tonsils are pretty rounded, but they do seem, in that 5 to 7 mm sort of level. And there's a certain asymmetricity to it, but the child is usually asymptomatic, at
Yeah,
least
I
in the few
see.
cases I've seen.
I do see the asymmetry all the time, and I think the measurement criteria, as I said, is really based on the lower of the two tonsils. But I think if it's asymmetric, they're actually less likely to be symptomatic. And the reason is if you have one tonsil down there and the other one's up here, you actually have still more room. Whereas if both of them are down there, you're more likely to be squished. But I do see it all the time because we do coronal sequences with most of our protocols, and that's when it's really striking. You really notice it. Whereas on the sagittal, sometimes somebody will have measured one of the tonsils, and then you're looking, you're like, well, but the other one actually looks a lot lower. So I do see it, and I do think it probably, if one is down and the other is up, that they're much less likely to be symptomatic. I haven't seen any literature on that specifically, though.
Yeah, me too. I've tried searching for this a couple of times and then I just let it be and
Yeah,
just
and I think there's a lot with this that, what you're saying actually reflects that this is a pretty common thing. There's, some spotty literature out there, but these are questions that come up in my mind and I think other people's mind all the time.
Mhm.
You're like, I wonder what I should do with that.
Yeah. Yeah, I think that's about it from the questions, Maura. Thank you so much for your
Okay.
time and an awesome talk. And we've all learned so much. And I think all our reports are going to be so much better henceforth. Thank you so much,
All
Maura.
right. Very great to see you.
So good to see you too, Maura. Have a nice Sunday.
You too.
Bye.
Bye.